Good afternoon and welcome to today's webinar, Addressing Spirituality as Part of Neuropalliative Care. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. This webinar is being recorded. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenters by typing your questions into the questions box of the control panel, also located in the platform's dashboard. You may send in your questions at any time during the presentation. We will collect these and hope to include them during a Q&A session at the end of today's presentation. I'd like to share with you a couple slides before we begin. Wanted to bring your attention to a number of webinars that we held 2 weeks ago during Spiritual Care Week. There's a QR code and a bit.ly. You can access all the resources, recordings, slides if the presenter shared them at that website. We're also starting a new research network dedicated to mental health chaplaincy, and you can find a registration sign-up sheet on that same website. This Thursday, we have a webinar with Caroline Peacock, qualitative analysis of the role, experience, and perspective of spiritual health practitioners in psychedelic assisted therapy. That's at Thursday, 2 Eastern. Register for free. There's the QR code and the bit.ly. If you have found any of our resources and webinars helpful, we ask that you make a contribution. We are at 70% of our goal for the end of the year, so we are most grateful for any generosity you are so moved to make. And with that, I'd like to turn the hosting over to my friend Paul Gaushoot. Paul is a convener of our research network at Transforming Chaplaincy, our Hospital and Palliative Research Network. He is a research staff chaplain at MHealth Fairview, University of Minnesota Medical Center, and he's a current Ph.D. student at University of Maryland. Paul.
Thanks, Andy. Great to be with you all. And thanks so much for taking your time to join us for this conversation about spirituality and neuropalliative care. And I'll look forward to getting to our presenters here in just a moment. Next slide, please, Andy. But I do want to shamelessly plug the network. That's Kepler, Max Kepler. He is currently a right fielder for the Minnesota Twins. I'm a baseball fan. You're going to hear that theme just a little bit in case you've not tuned into any of our webinars previously. But please consider joining us to connect, inform, and explore and coordinate what the spiritual care evidence means for our work, especially related to hospice and palliative care. Next slide, please, Andy. So to that end, I would invite you to pull out your smartphone or whatever device you might have to capture this QR code to join us there. I'll be there in just a little bit to let you in and be a part of us. There are 1,000 plus members. We'd love to have you slide in just like the great legend Jackie Robinson is doing here on this photo. Next slide, please. And here's a moment we've all kind of been waiting for. I want to introduce our esteemed presenters today that are generously joining us to offer their wisdom and expertise toward how it is that we apply this toward our work that we do in the interprofessional space, especially related to the spirituality. So first I want to introduce Dr. Benzi Kluger. He is out of the University of Rochester Medical Center in New York, as opposed to what's just south of me here in Minneapolis. He is professor of neurology and medicine and is a palliative care researcher. He's internationally recognized leader in the emerging field of neuropalliative care, and he's the founding president of the International Neuropalliative Care Society. It's an organization dedicated to improving models of care for persons living with neurologic illness and their families. Dr. Kluger's research focuses on developing, testing, and implementing palliative care interventions for persons living with Parkinson's and other neurologic illnesses, and improving our understanding and treatment of non-motor symptoms in Parkinson's, including fatigue and cognitive dysfunction. He is also working on several writing projects. Please check out the website that's here on this slide, benzikluger.com, related to empowering people living with serious illness to better advocate for themselves and to avoid potentially dangerous and expensive medical BS. You couldn't have said it better yourself, Dr. Kluger. Thanks so much for being with us, Benzi. And if Benzi was stepping up to the plate. His walk-up song would be Everyday Sunshine by Fishbone. Our next presenter that we are so grateful to have with us is Dr. Sue Ouellette, also at the University of Rochester Medical Center. She is chaplain in the Division of Neurology and supportive and palliative care in the Department of Neurology at Rochester Medical Center there. Additionally, she serves as the Department of Neurology as the Associate Chair for Physician Wellbeing. She is a licensed marriage and family therapist who provides mental health services to persons with neurological disorders through the Department of Psychiatry in her setting. Dr. Ouellette also received her Ph.D. at Kent State University and her Master's of Divinity at Colgate Crozier Divinity School. I'm almost out of breath. This is some amazing work that you've done, Dr. Ouellette, and she's author of numerous publications focused primarily on mental health of persons who are deaf and hard of hearing, and is the project director for many grants in this area. I will come calling. Don't worry about that, Dr. Ouellette. In addition to all these things, she is an ordained Episcopal deacon. And if Dr. Ouellette, if you were walking to the plate, you would be playing the walk-up song, I'm a Believer, by the Monkees. Got a lot of good memories watching them on TV as a kid. And moderating this conversation is a longtime friend and co-worker, so to speak, in this field, also a Transforming Chaplaincy Research Fellow together with me back in the day. This is Shelley Varner-Perez. Shelley is a board-certified chaplain with more than a decade of bedside clinical experience. She currently serves as Senior Program Manager for Spiritual Care Research at Indiana University Health in Indianapolis. Shelley holds roles as the Chaplain-Researcher with the Daniel F. Evans Center for Spiritual and Religious Values at IU Health as an affiliated research scientist, with the Center for Aging Research at the, I always get this wrong, Shelley, if you're off mute, please say it, Regenstrief Institute in Indy.
Regenstrief.
Yeah, you said it. Shelley, thank you, is a PhD student in Health and Rehabilitation Sciences at IU Indy School of Health and Human Sciences. And Shelley, if you were walking up to the plate, you would select Try Everything by Shakira, must be a 7 on the Enneagram. Hey, Shelley, thank you. Dr. Ouellette, Dr. Kluger, thank you so much for being with us. I'm going to turn it over to, I'm going to guess, I think, Benzi, you are going first here, so I'm going to duck out, and thank you so much to you as presenters, moderator. Look forward to the conversation ahead.
Thanks, Paul. And yeah, so I was wanting to give a talk today that would be complementary to my partner in crime, Sue, and try to do something that's really research focused, just given the goals of transforming chaplaincy. So I'll share some research lessons from my work with palliative care and Parkinson's and make it as spiritually oriented as possible. And almost all of my work does have a spiritual dimension. And as you'll hear from Sue, the importance of spiritual well-being is I think, very looms large for patients with neurologic and neurodegenerative diseases. Next slide. So as disclosures, I've gotten a bunch of funding for this work, and if people are interested, I'm always happy to talk to young researchers or older researchers who want to collaborate or discuss ideas, and we have a works in progress session at the University of Rochester where you could do so. Next slide. Also, as somebody who has seen those kinds of slides before and can find them intimidating, would just like to let people know that I've had many multiple orders of magnitude more grants rejected than accepted. And I would say, particularly for spirituality, the advice I would give and the advice I give my mentees is that if you get something rejected, it doesn't mean that your idea is bad. It just means that you haven't found the right way to make that reviewer care about what you care about. And so finding another way to do it, sometimes maybe even having to publish a paper or get some more pilot data, but just to know in your heart that the work that you're doing is important, and it's important to get reviewers to care about it so that you can make papers and change the world. Next slide. So I thought it would be fun to just do a kind of a top 10 of lessons, and this ties into the last statement, which is to dream big. And as you're thinking about what you want to do as a chaplain researcher, know that the things that you are touching on are really the most important things, in my experience, that patients and care partners and family care about. They care about being connected to family. They care about dignity towards the end of life. They care about joy. They care about independence. They want to understand, make sense of their journey. So those are huge things. And even though reviewers are used to thinking about biomedical compounds and molecules and genes, I think it's up to us to change that. And so for me, the big dream was a little over 10 years ago was, could we transform Parkinson's care so that palliative care is integrated into it? And over the last decade, we have made significant progress to that goal. And so if I had dreamt small 10 years ago, we definitely wouldn't be where we are today. Next slide. Connected to that is, I would say, a lesson is that if it doesn't work in the real world, it doesn't really work. And so I think research is filled with examples of people who have done things in their ivory towers and have done things that worked when they had $1 million of extra grant money. And after the grant was over, you never heard about that project again. And so, you know, to push you to think about from the very get-go, how is this going to be scalable? How is this going to be disseminated? How is this going to work in the real world? And if they don't have an answer to those questions, then maybe go back to the drawing board, because we don't need more things that work in ivory towers and don't work for everyone. And I would say maybe related to that is that we also want to think about equity in addition to working in the real world. So not just working in the real world, but working in the real world for everybody, even people who are traditionally underserved. Next slide. Lesson 2 is to engage with the real experts on your illness of choice. For me, those are people with Parkinson's disease, and I have collaborated with people with Parkinson's and their families for over a decade, and it's been super informative to me. To give an example of how this has informed some of the spiritual aspects of the research that I do, I can remember actually one of my first introductions to palliative care was going to a Parkinson's support group. And some of the things that people wanted to talk about at that support group included death with dignity, and notably was a patient with Parkinson's who pushed forward the medical aid in dying law in Colorado. It was about fear of dementia. It was about changes and threats to identity. It was about how getting a diagnosis of Parkinson's was like a bomb being dropped in their life. It was how Parkinson's uniquely affects identity, how it affects people's social connections. And so all of those insights, which I think are really essentially spiritual, are things that chaplains are great at, are not things that I would have known about without talking to patients and families, and definitely were not part of my clinical and research education. Next slide. Clinical innovation drives person-centered research, and this is an example from one of my mentors, Janice Miyazaki, an example for me of how quality improvement projects not only led to papers that helped us to get grants, but I think helped us to perfect our intervention. And I see this in grants a lot, that people will come up with an idea and write it down and go right to a grant, and they never socialize the idea, they never try it out in clinic, they never perfect it. And the disadvantage of that is that you end up with a theoretically driven intervention that may look very good on paper, but may have some flaws in the real world. So I would really encourage people to use their ideas, perfect their ideas, perhaps even develop their ideas in clinic and in the hospital, and then bring those to research. Next slide. The research journey benefits from a roadmap. I think the world of spirituality and research would be really ripe for something that we did in the world of Parkinson's and palliative care, which would be to have a working group to sit down and to think about where are we as a field? What are the gaps? What do we know? What can we learn from other closely related areas? And where do we want to go? And this roadmap that we developed at a project, we didn't publish it till 2017, but we met in 2013, really did provide a pretty amazingly accurate 10-year roadmap for the research that we're doing. And happy to talk to people more about opportunities, including with the International Neuropalliative Care Society, for convening these types of working groups or Delphi panels. Next slide. So lesson 5, I would say, is to choose a great research question and propose what I would say are real hypotheses as opposed to just predictions. And then this is, again, something that I really push my mentees on and push myself on, is to make sure that I'm doing research that may have some chance of changing the world. And so really thinking about and going deep, what is the current state of the field and where are the major gaps? And that could be going outside of the research literature and going into the clinic and talking to people and see what are we not doing, or what should we be doing that we're not doing well. Thinking about where your research falls on the NIH stage model, and I'm going to show that in one slide, but I think it's really important, particularly for chaplains and palliative care researchers, to think about clinical trials. I was just at a symposium last week, and I think the term that was used by an awesome researcher, Nick Odom, was that we don't want to spend too much time admiring problems, that we want to spend a lot of time fixing problems, and that's where getting to clinical trials is important. Thinking about, and this is a paper that I refer people to all the time, George Gopin's classic article on scientific writing and Scientific American, but really thinking about who is the hero of the story. Is the hero of the story dignity therapy? Is the hero of the story thinking about suffering? Is the hero of the story changing the way neurologists interview patients? But to really be specific about that, and a lot of grants aren't very clear on who the hero is, and I think without a clear hero, there's not a hero's journey, and the reviewers don't root for you, but I think more importantly, your project just kind of fizzles out because we don't know where it's going. Thinking about the long-term goals, and then having a real hypothesis, and so not just having a prediction. So a prediction would be that the FACIT score is going to improve by 2 points, but to have a real hypothesis such as that by speaking to dignity, people living with Parkinson's have more spiritual resilience, and that might be measured by your prediction, but that underlying hypothesis is going to inform a lot of your work, including how you pivot if things don't work out according to your predictions. Next slide. So this is the NIH stage model. It comes from a paper by Onken, O-N-K-E-N, who's a program officer at NIA, and would highly recommend anybody who is doing pragmatic research that has any hope of changing the world to look at it and to mention it in your grants. It's just very central to the work that we do. Next slide. Choosing the right outcomes. And I think for spiritual interventions and for spiritual research, this is huge. And there aren't a lot of great spiritual outcomes out there. Maybe we'll talk about this more in our Q&A session. But for this, I like people to think about, and I've done this before, is to read through, say we were using the FACIT spiritual well-being, go through it item by item. And for each item, think about, is this asking a question that's meaningful? And is this asking a question that I think I'm going to be able to change the answer on with my intervention? And if not, if the answer is no to either of those questions, then you may want to go back to the drawing board and either find another outcome, or potentially what's needed could be to develop a new outcome measure. But if it's not something you can realistically improve, and for spiritual interventions, there may not be a lot of literature to see if other people have used this outcome and if they've been able to move the needle on it. Thinking about what's meaningful improvement, and this could be statistical, but I think way better is if you can think about what would it be clinically. So is this a 3-point improvement? Is this going from very much to a lot? Is this going from nothing to moderate? So really thinking practically, what does clinical improvement look like, and using that to drive your power analysis rather than just statistics. Quality of life, I would say, is generally not the best outcome for studies. If you're doing something specific, measure something specific. Anytime you use a quality of life outcome, you run the risk of diluting your effect, and not every quality of life outcome, in fact, almost all quality of life outcomes measure things a little bit differently. In the world of Parkinson's, we did some research showing that the most commonly used health-related quality of life outcome measure wasn't correlated with spiritual well-being, whereas a more generic quality of life, a general quality of life outcome was correlated with spiritual well-being. So we want to keep those in mind. You want to think about other outcomes, which could include things that you'd want to do in your mediation analysis, could be things that you want to set yourself up for success, could be things that you want to use later for perhaps doing a clinometric paper. When do you expect your maximum effect? A lot of times we just do 3 months or 12 weeks or 6 months because it's convenient, but it's good to know when you think things are going to be at their best. And then using mixed methods is always a good thing. So even if you have a good outcome measure, qualitative data just makes whatever you're doing a lot richer, and helps you to better understand how you can optimize things that went well or how you can fix things that didn't. Next slide. I would also put in a plug here to not forget positive outcomes. We do a lot of work in medicine that's framing things negatively, and even in spirituality, I guess we do look at spiritual well-being, but I think a lot of times we also look at spiritual distress. And so to think about it as you're looking at your work, is it possible to have positive goals, things like joy, things like love, things like meaning, as opposed to looking at anxiety and distress? And you know, either one is possible, but I would just say that in research and in medicine, we do have a bias to wanting to fix the negative, and we tend to ignore improving the positive. But I would say in my research, and this may be true for some of you as well, is that sometimes we have a disconnect, that we have a great intervention and we can't measure the benefit, and it's because we're not measuring benefit, we're measuring only worsening, less worsening. And so if we add on measures, for example, positive outcome, positive aspects of caregiving, we might be able to see a benefit that we have from a great intervention that just doesn't work with a mechanism that's lessening something that's bad. And in a disease like Parkinson's that's progressive, we may not be able to impact the badness of it. But perhaps we could add on things. We can add on awe and joy and transcendence and meaning that may make the badness less bad. Next slide. We want to choose the right participants. This is a common thing that happens, is that we just use random sampling. We bring everybody into to our intervention. And if we're focused on, you know, as an example, reducing anxiety, if the people that we bring into our intervention don't have anxiety to begin with, we're not going to see an effect. So we want to make sure our inclusion criteria align with our outcomes and intervention. And we also don't want to exclude people who don't need to be excluded, because it's really hard to recruit. In the world of Parkinson's, you know, sometimes we'll exclude people because they have dementia or they have DBS or they have X, Y, or Z, or they have a comorbid illness. But I think we need to think about, particularly with an intervention like spiritual care, do we really need to exclude those people? And would we really exclude them from clinical care in the real world? If not, I think it's our job then to get the reviewers to see why we are maybe not using the traditional inclusion-exclusion criteria that people expect for our field. Next slide. So we want to also implement the right intervention. And this can take some work, and this can take some steps. And going back to the Unken model, there may be several cycles before you have something that's really worthy of doing a large randomized trial. You want to think about, does your intervention align with the outcomes you chose? Does it align with the participants you chose? Have you tested it out in clinic? In this case, how are you defining and operationalizing spiritual care? And it may be that you have a very focused intervention, for example, something like dignity therapy, or it may be that you're doing something that's a bit messier, in which case you may have to use more work to be able to operationalize how you're defining spiritual care. And if it is something messier, you also want to plan, how are you going to know what's the key parts of what you're doing that's making a benefit? How are you going to control fidelity and quality, particularly if you have multiple interventionists? And what are their qualifications? Is it enough to be a chaplain? Do people need to do extra training? Is it something that social workers or nurses or other people can do? So all those things are things that you want to think about. And particularly if we think back to our first slides, if we want this to be scalable, how do we make sure that this is going to be something that, you know, for example, if this is the end goal, that a community healthcare worker can do ideally within the next 5 or 10 years whenever you're successful. Next slide. Bringing together the right team is important, and this includes making sure you have the skills and expertise you need to deliver the intervention, the skills and expertise you need to conduct the research, which could include having qualitative experts, could include having implementation experts. And there's a difference here between having the skills and expertise you need to do the research and the skills and expertise you need to get the grant. So sometimes you'll have people on your grant who aren't doing a lot, but they're helping you to get the funding. And then once you get the grant, you're welcome to do what you can with your money. Don't tell the NIH I told you that, but it's true that you do have a certain amount of flexibility to do things a little bit differently than you do in the grant. But sometimes you need people who have more experience than you on the grant to get people to trust you, and it's good to keep them involved. But you also may know that in the real world, once you get the grant, that they may not be doing everything, or at least initially, they may, you know, kind of back off as you develop the expertise to continue to do it. You definitely don't want to have too many cooks in the kitchen, and you want to think about, are these going to be fun people to work with? You know, I don't think we pay enough attention to that, but I love the people I work with, and it makes the work very much more sustainable. Next slide. So the last plug, and then turn things over to Sue, is that providers and researchers need and want and desire spiritual training and support. This first editorial, which I wrote a while ago, talks about my own journey into palliative care, and it ended up being a spiritual journey. I didn't recognize it as a spiritual journey to begin with, and since I've made that transformation, I've connected with a lot of neurology residents, a lot of providers, and we don't talk enough about things like joy and love and meaning and connection in neurology or in medicine in general. There's a lot of burnout. So I think, the work you're doing is fulfilling a huge need for patients and families, but it may also be filling a huge need for neurologists and doctors and healthcare administrators and researchers who aren't doing things that are really important and that are really feeding their soul. So with that, hopefully I gave you some fuel for conversation later, and I will turn things over to my colleague, Sue.
Thank you, Benzi. I have no disclosures today, and I will take a little bit more of a clinical perspective here, talking a little bit about chaplaincy in the area of neuropalliative care. And I think one of the first questions is, what's so special about neuropalliative care? Why is it so important to look at the chaplain's role here and to consider the importance of spirituality in this particular setting? Next slide, please. What is unique about neurological conditions I have found is that they affect body, mind, and soul. Because many of them are progressive in nature, they require constant revision for the patient and the patient's family in making meaning. They can be very unpredictable at times. The course for each individual may differ very much from the course of another individual. They may or may not have specific treatment available, so hopelessness and demoralization are a concern. A patient said to me, it's hard to believe that I feel better today than I ever will again, probably, knowing that the road leads to more symptoms, not less. Neurological conditions can be very isolating. Communication is often restricted because of the disease. Movement is often restricted, and self-imposed isolation is very common with these patients. They're embarrassed because they may not have the ability to eat in quite as proper a way as they once did, or they may need to use the restroom often and really don't want to embarrass their family by having to do that. So the losses here are not only multiple, but they're continual. And as a result, the effect of the illness is on the entire individual's family, as well as the person themselves who's dealing with the disorder. We know from a number of studies that we have looked at that patients with neurological illnesses who have strong spiritual support have a higher degree of happiness, better quality of life overall, and that spirituality and spiritual care are positively associated with quality of life, even beyond the length of the illness. So lots of good reasons to make sure that spiritual care is a part of the treatment plan for these patients. Next slide, please. So although spiritual strength can result in positive consequences, there is also a lot of spiritual distress that occurs with neurological illnesses. And I want to take a look at that for a few moments. Next slide. I've grouped some of these challenges into some broad categories. There are others, I'm sure, but these are some that I see most often. The existential challenges with neurological conditions. I was thinking primarily here of Parkinson's, ALS, brain tumors, multiple sclerosis, and then there's a bunch of lower incidence neurological conditions as well. But I think some of the things that they have in common here are challenges regarding who am I now that I'm not able to do the things that I used to be able to do? I can't work anymore. I can't take care of my family the way I used to. I can't keep the house or the yard up the way I am accustomed to. I can't contribute to the community I live in anymore. I feel isolated. I feel useless is a common thing that I hear from patients. Hopelessness can be a very major issue with some of the progressive diseases. Adjusting to a constantly changing condition requires a great amount of existential searching and making sense out of what's happening. One's body is changing, one's voice is changing, one's appearance may be changing. All of these change the conception of self that the individual is dealing with. Next slide, please. I mentioned body image. How we look affects how we feel. For many patients, this whole sense of dignity and self-worth gets very much wrapped up in the consequences of the disease. The individual may feel invisible because of the condition that they're dealing with. Even in the less degenerative diseases, although it can be degenerative as well, multiple sclerosis patients very often are young, first of all, but secondly, talk to me about how nobody understands what they're going through. Unlike some of the other conditions where the individual might be using a wheelchair or a cane or a walker, some of the patients with MS may look pretty normal on the outside, pretty healthy on the outside, and yet receive very negative feedback from people around them because of their lack of energy and lack of ability to sustain a high level of activity. The combination being young and having kind of an invisible disability is a very difficult one for many, many patients. Next slide, please. The personal issues, I think, are very important. One of the big ones is the loss of employment. People who have defined themselves by their career are suddenly at a loss for figuring out, who am I now that I can't do those things anymore, now that I don't fit into that position? The loss of agency, others making choices for you. The inability to drive is a very difficult one that many patients face. Many of the Parkinson's patients I work with talk with me about how hard it is when you've always been able to just turn the key and go where you want to go, to have to find a ride, to have to figure out a way to get there by public transportation. So much of our sense of adulthood is wrapped up in being able to drive, that when you lose that, it's huge. Not being able to do your household chores, not being able to engage in activities that you really enjoyed before, running, biking, having others tell you what you can and can't do. I had a patient who had Parkinson's disease, and he always used power tools to fix things around the home. And he just does not understand now, due to some of the cognitive effects of his disease, why he can't continue to do those things. And when the family tells him he can't do them anymore, he becomes very, very angry and anxious as a result. Just doesn't make sense to him. I have a patient with MS whose husband recently told her she can't drive anymore. He makes most of the decisions in her life now, and she feels very controlled as a result. Many of these diseases involve confronting mortality. End-of-life issues become a major concern. You may find that the patient with Parkinson's, for example, wants to sit and talk with you about what happens when I get to the point where life is no longer worth living. What are my choices? Do I go to a state where there is an opportunity to have medical aid in dying? These are all filled with religious and spiritual connotations that are huge. Next slide, please. The relational issues are the other category that I would mention. The fear of being a burden to other people. The role changes, having been head of a family and suddenly being the one that the family is taking care of. Having been husband and breadwinner or wife and breadwinner, suddenly husband and wife turn into patient and caregiver. This can result in marital changes and even conflicts. The family may disagree about the care plan for the individual, and that may result in family problems. It's not unusual for us to have a whole family in the room to talk about the effect of this disease on each of them and to make decisions about how to go forward as a team. Next slide, please. I want to skip here for just a minute to a new area and talk a little bit about another challenge. All of us who are chaplains deal with grief and loss, and this is a bit of a different take on it that really fits with these degenerative illnesses from my point of view. This was the thinking of a man by the name of Dr. Kenneth Moses, a psychologist. Dr. Moses wrote a couple of articles in a book, actually. He did not become one of the big names, but his work has always shaped my work as a chaplain, and I owe much to him. So, Ken, if you're out there somewhere, I hope you get this word. He talks about grief as an automatic, unlearned feeling process. He says grief is natural and it's expected and it doesn't need to be fixed. So in these illnesses that we're talking about, perhaps no one has died or is dying imminently, but there are ideas, core level dreams, yearnings and projections for the future that people have that die when these illnesses are diagnosed. They die not only for the patient who now is not going to have the dream that they had of traveling all over the world and, you know, sitting back in the rocking chair along the lake and just taking it all in necessarily, but they die for the family members who shared that dream. And for all who are touched by this illness. So Moses says that grief is the process of letting go of shattered dreams. And this phrase is a very important one to me in my work. Wandering in a dreamless void until they're able to find a new and more congruent dream. So the old dreams are destroyed, people are at a loss, and they wander around without quite knowing what the future will bring until they are able to start to attach to a new dream. And I think the chaplain's role in helping that process to move along and to find new dreams is a really important one. Next slide, please. I'll talk for just a moment about some of the different emotions that we see. And this relates to the grief process as well. You may recognize some of these emotions that are listed as stages of grief in the old stage models that we all studied when we were in school. I personally don't believe in stage models. I have a wonderful slide that I like to use that has one of the models and shows the graph going across each of the stages. Then the next slide is this random scattergram that says what my grief process looks like. We don't grieve in nice, normal, orderly ways. So we do see a lot of depression and anxiety. These are complicated and difficult to sort out. Some of them are related to the disease itself and the disease process. Some are related to the effects of the medications that are being given, and some are just plain existential depression and anxiety. Often we see depression that is a part of the grief process rather than a pathological depression that needs to be treated as such. And lastly, as we all know, there's no need to fix emotions. Just being with them is quite enough. I'd like to take the last couple of minutes to talk about the next slide, please. I've mentioned often that the family is very much involved. Working with caregivers here is every bit as important as working with the patients. And this is an ongoing process, and like maybe seeing the family in the hospital for a short period of time, these relationships can be long-lasting, deep, and very significant. Spirituality is one way of coping for caregivers. Caregivers very often experience spiritual distress because of the changes in the relationship. I remember one wife saying to me, "I feel like I'm losing him a little bit every day." Profound statement to think about. Caregivers have identity issues of their own. They are isolated as well by virtue of their caregiving responsibilities. They feel grief and loss as well. Guilt is a common emotion in both patients and caregivers. Patients feel guilty because their loved ones are working so hard to care for them. Caregivers feel guilty because they have myriad feelings, some of which are not always the most socially acceptable feelings to have, but very normal. And of course, there's that fear of just losing their loved one. There's an ambiguous loss that comes, the person sitting right next to you, but you are missing them. I've had caregivers say that to me. We're in the same room and I miss him so much. Next slide, please. Actually, I skipped over one. Next slide. Okay, so it's really important to do a full assessment of the caregiver's need. As you assess the patient, also assess the caregiver. These are the items on this slide are ones that you're familiar with that you would want to take a look at. And then next slide. And you could go just right to the next slide. So as part of the neuropalliative care team, these are some of the things that a chaplain does. If you're working in this area, you could expect to be doing spiritual assessment, developing treatment plans, which of course you already do, doing a lot of values clarification regarding illness and treatment and end of life, looking at spiritual distress, working with a lot of existential issues, supporting family members and care partners, and supporting each other. This is hard work that we do, all of us in the field. and there is great need to support each other, and then making referrals out for mental health care or specific religious care. Next slide. So just a couple of summary points, maybe takeaways if you like to have a few specific points to remember. These would be the ones I'd want you to take with you. Neurological diseases can be devastating, not only from the physical or mental point of view, but also emotionally and spiritually. That caregivers are so important to pay attention to and provide support for. That our job is to help patients make sense out of what's happening to them. That we're very concerned about quality of life and spiritual well-being. And as Dr. Kluger said, bringing meaning and joy and beauty and awe into the lives of patients and caregivers. And the spiritual orientation is, of course, a very important lens for all of these patients. And last slides. Thank you. Thank you for your attention. I think we'll open for questions now, right, Shelley?
We are. Thank you, Sue and Benzi, so much for those helpful talking points, both about research in neuropalliative care and giving attention to spiritual care needs of folks dealing with neuropalliative care and their caregivers. It's so fantastic to have researcher, clinician, and a chaplain on this call today. So thank you. We have one question that has come in from Chuck that I will pitch to both of you for some discussion. Chuck writes, more and more research is indicating that the nuns and the spiritual but not religious do not do as well as folks who attend church, synagogue, mosque weekly in terms of psychological and physical well-being long term. Does this show up in neurologically progressive diseases as well?
Benzi, oh, I was just going to say that I think what I have found to be important is that the person has some type of spiritual framework, perhaps more important than even whether or not they're sitting in church on Sunday, helping the patient to develop a spiritual framework if they don't already have one is really critical. Would I add, Benzi?
Yeah, I'm not aware of anyone looking at that specifically in neurologic illnesses. I'm familiar with the research, and I don't know, we can argue about, kind of differences between, religiosity and spirituality, but I agree with Sue that I think if people have a framework, if they have practices that we could hang on to and things to build off of, then yeah, I don't know, I definitely feel more hopeful for our chances to have a better journey. I think if people don't have a lot of spiritual resources coming in, as Sue outlined, that neurologic illnesses are just so threatening to core aspects of our identity that it's really hard, using just material tools to pull yourself out of that.
Great.
Thank you both. We have another question that's come in from the chat box from Adrian. How can we best ask patients about their spiritual needs? And the piece that I would add to this about asking about spiritual needs is a piece that Benzi touched on, which is, and Sue mentioned as well, which is addressing positive aspects of spirituality. How do you find yourselves doing that in your clinic as you work together and with your interprofessional team?
Sure, I could talk about, for myself, how I ask it, and then also what I recommend other non-chaplain clinicians do for screening, and then Sue could give a more detailed view of her approach as a chaplain. But as a non-chaplain and as somebody teaching residents, I find that questions that don't use the word spirituality or religion tend to be more effective. So I often ask people, what's the toughest part of this for you? Where do you find joy? Where do you find meaning? What are your sources of strengths? How have you gotten through tough times before? And those tend to point us in the right direction. And they also tend to be easier questions for non-chaplains to ask, who get very intimidated, even by things like the FICA, which it just seems like it's kind of too long and maybe not practical, and may not always resonate with that person's language and what they feel comfortable doing.
Mm-hmm. Yeah, I would agree. Taking a really good history is important, and I try to include in that history the types of things that brought the person joy in the past, because those are stepping stones to build on, to see if there's some way we can adapt that. But I do just ask people if they have some type of framework, and I will say religious or otherwise, that helps you to make sense out of this, to begin to grapple with those questions that come up, the why me questions, the what did I do to make this happen questions, that kind of thing.
I can add one other thing, and I don't know if you have the ability to share it, but I wrote a paper recently with Bob Arnold on the total enjoyment of life, which is kind of a complementary viewpoint to the total pain of illness. And so that could also provide like a quick mental checklist of what are the opportunities here. And so we could look at cognitive and meaning. We could look at pleasure, which is actually a big one. Could be as simple as holding hands or touch. Emotional happiness. I think spirituality is a big one, which it includes, which I think a lot of clinicians don't think about, but one of the ways we can be valuable is helping patients and families with letting go, with finding transcendence, and then, you know, social aspects of love, which, you know, I think for most people, you know, in terms of finding meaning, it often comes down to family and friends, and just really, you know, sometimes twisting people's arm. Actually, just earlier this week, I really, you know, strongly encourage somebody to go to their sister's house for Thanksgiving, even though it may be difficult, even though they may need to ask for help, because they're, you know, I don't think anyone's going to regret that decision, honestly, at the end of the day. So, but thinking about it systematically of what are these different dimensions of enjoyment, and making sure that we don't miss something that may be, you know, relatively easy to hit.
Thank you both. And I think Paul was maybe one step ahead on the article Total Enjoyment, Benzi. And Paul recently posted that in the Hospice and Palliative Care Spiritual Care Research Network. So it's another plug to make sure that folks who haven't joined that network, Paul's constantly curating these resources for us. And that was one of the most recent ones, Benzi. So thank you for bringing that up. And I also added in the chat, in addition to the wonderful resources that both of you have mentioned, a pocket guide that was published not too long ago, top 10 tips clinicians need to know for addressing spirituality in serious illness. So that provides some additional quick tips and resources. Adrian and others who had asked this question about addressing spiritual needs, addressing joy, awe, and these other things are in the top 10 tips article that I just put in the chat. So thank you. I have an additional question here from Anne. Anne is from Pastoral Care Team at Marymount University Hospice in Cork, Ireland. Anne writes, I find that these patients are especially at risk in the area of suicidal ideation. Do you suggest specific spiritual responses to neurological patients in this regard?
I could start, and then Sue
You can
share
start, Benzi.
perspectives. Yeah, sure. One is to say, in certain illnesses like Huntington's disease, the rate of suicide is notably higher, and so we definitely want to keep that in the back of our mind to take those seriously. I think part of my questions when I ask people about that is delving a little bit deeper into, is this truly about suicide? Is this about not caring if you die? Is this about trying to point towards death with dignity or medically and dying? But I guess sometimes exploring deeper just what people mean by it, because I would say more often than not, I don't know, Sue, in your experience, but I think a lot of times in this population, a lot of suicidal ideation comes down to feeling like a burden, and comes down to feeling like their life is not worthwhile anymore, and that they are more of a burden than a joy to the people in their life. And so there's kind of this deep existential sadness that's driving it more, and I think talking about how to fill that is maybe, sometimes more fruitful than, kind of traditional suicide counseling. defer to
No.
Sue and let her know her impressions.
No, I would agree entirely. I see talk about wishing wasn't here anymore, or about ending one's life, as an opportunity to talk about the deep pain that an individual is feeling. Very often at the heart of it, you'll find is fear, because all of these are illnesses that don't get better. And the person is just so frightened about what the future brings that they are having difficulty even imagining facing something worse than what they're dealing with right then. So just being with the person in that place and really hearing, quote unquote, their distress, I think is one of the most important interventions.
Okay. I guess as a team-based practice, I don't know, Sue, if this is a question that you asked specifically. It's one that I often ask is when you mentioned fear, it triggered in my mind that when people are afraid of death, which can kind of paradoxically also be a prompt for death with dignity or thinking about suicide.
Mm-hmm.
You know, I was asking people, are they afraid about what happens before they die or what happens after? And I think when it's before they die, then I may have, you know, some more to offer in terms of talking about pain control and hospice and things like that. And then certainly if it's after, you know, certainly Sue and other chaplains have a lot to offer, because then it, you know, it gets to things that, you know, are much more existential or spiritual.
Sometimes an opportunity to use a question that I learned from Benzi, which is, what are the things that this disease can't take away from you?
That's a fantastic question, and a good resource to have in one's tool belt. I think it relates to one of the questions that we received from Liz Sauber, who's here at IU. Could you give some examples of how you bring meaning, joy, and awe to your patients? I know we spoke to this a little bit, but perhaps you have an additional example of how that can be incorporated.
Yeah, I could share a few off the top of my head, and Sue could, I'm sure, as well. Yeah, and just in the last month, thinking, one is a patient who's near and dear to my heart, who I saw in person, which is rare because most of the time when I see them, they are in their RV in a place that I'd rather be. So they're in Savannah or Florida, or they're going down Route 66. But you know, modifying their RV and encouragement to travel, I mean, that's kind of, you know, kind of big joy. In a way, a lot of times joy comes down to encouragement to do ordinary things, which could be eating ice cream every night, could be holding hands, could be sharing a sunset, could be listening to music. So just, you know, I would say more often than not, when we ask about it, it's not things that people want to check off their bucket list. It's ordinary things. And I think part of where me and our team can be helpful is giving patients and families permission to enjoy life despite everything else that's going on. And a lot of times, you know, even in our first visit, you know, I'll say, you know, we've talked about a lot of tough things and we want to make sure we honor your grief, but at the same time, we don't want to lose opportunities to find joy and meaning and love. So let's try to keep that on the table. Even, you know, as much as, you know, I usually have clinic on Friday afternoons, I'll say, you know, we had a tough session today. I'd encourage you to do something nice for yourself this evening or this weekend. So it, you know, could be big things, but could be small things. And I'll turn things over to Sue and how she approaches it.
Well, sometimes it's just really getting creative with people. One of my really early patients was a woman in her early 60s with pretty severe MS, pretty limiting MS, and she had been a gardener. She absolutely loved gardening, and she couldn't get out and dig in the dirt anymore, and it really, really demoralized her. And we got together with some of her family members, and they created a ramp for her that she could use her walker to come down the ramp, and there was a potting bench, and she could sit at the potting bench, and she potted plants and then gave them away to her neighbors, which was really a very lovely thing, and it made a huge difference in her life. Lots of couples I will sit and talk with about traveling the plans that they'd like to travel. And it might start as, well, we can't do those things that we thought we would do. And then we end up talking about, well, what if you did this? What if you did that? And we'll come up with a creative solution and it'll work.
Yeah, it sounds like some of that creativity for modifications and just encouraging folks to consider those potentials for even small moments of joy and awe really can be beneficial. Sue and Benzi, thank you so much for joining us today. I see Paul's back on to wrap us up.
Yeah, I just want to echo that. Thanks, Dr. Ouellette, Dr. Kluger, and Shelley. Thank you so much for your time, your generosity, the wisdom that you've shared. The sign of a good webinar is that we perhaps didn't answer all the questions, but that many linger and carry us forward into that wisdom that we keep seeking. So thanks for the work you do, whether it be research and or sitting at the chair side of the people that you care and love so much. Thanks, friends, for joining us too as well. Look forward to seeing you at our next Transforming Chaplaincy webinar. Be well, everyone.
Take care.
Thank you.